And this is our protocol. So it's relatively straightforward. You've got regular narrow complex tachycardia, irregular narrow complex tachycardia, and then you've got regular wide complex tachycardia. And we broke this down to make it pretty simple for you. For regular narrow complex tachycardia, we generally start off with adenosine, but you can also give cardizem. Now, a way to read this protocol is that you do not have to go through each bullet point before you can give the next medication. Generally, that's true with adenosine. Now, I'm showing you how to use this protocol. All right, this is your education on it. Now, if I've got a patient that, the protocol says I need to give adenosine first, well, that's not what it's saying, first of all. But this patient could say, listen, I've had adenosine before, and it caused extreme discomfort. Please don't give it to me. Okay, then you can try cardizem or diltiazem. Let's say I give the adenosine, no change. I give the 12 of adenosine, no change. Then you can give cardizem. Now, regular wide complex tachycardia, we talked about situations in which you might want to give adenosine versus go straight to amiodarone or give lidocaine instead of amiodarone. This is your choice. And then these pearls are especially useful. A wide complex irregular rhythm should be considered pre-excited AFib. Extreme care must be taken in these patients. And of course, this is when giving cardizem for patients older than 65, recommended maximum initial dose of 10 and maximum second dose of 20. So how do you decide? This is I'm still confused. Just give me the too long didn't read version. All right, so if it's wide, fast, and regular, and it's over 130, then if they're stable, it's amiodarone. Lidocaine, if you're certain that it's VTAC based on the history that you have obtained. If it's not really wide or the patient's young, consider amio. If they're unstable, cardiovertim at 100. Now, our cardioversions have been simplified. This is a way which we made, I need to treat this patient now, make it as simple as possible. This is what we have done to do that. Your initial energy for cardioversion is 100 for all adults, for all rhythms, 100. All right. So moving forward, if they have SVT or AVNRT, we really need to replace SVT with AVNRT. That is more accurate and more specific. If it's narrow, fast, regular, and more than 150, modified Valsalva, adenosine. And then if that doesn't work or the patient doesn't want adenosine, it's cardizem, AFib, flutter, RVR, narrow, fast, and irregular. That should say irregular, not regular. If it is abrupt onset and you suspect it's not compensatory for something else, then cardizem. Torsades, if they're in torsades, it's defibrillation. If they're unstable, and IV magnesium. If it's polymorphic VTAC, it is amiodarone or lidocaine. All right, so now we're going to briefly cover some common tachycardia classifications to further drive this home. Sinus tachycardia, pretty obvious. You've got a P wave for every QRS. And now, where are the P waves? Well, if you can see my mouse pointer, the easiest lead to find P waves is in V1. You'll see a little blip that's pretty consistent and before each complex, each QRS. This is sinus tachycardia. Don't mistake sinus tach for SVT. That can lead you down some treatment misadventures. And you're not treating what's actually wrong with the patient, the underlying problem. So be very careful misclassifying sinus attack as SVT. Fix the underlying cause. AFib, it is irregularly irregular. I might see, like in V2, possibly some P waves that look like it might correlate with the QRS, but in V1 you'll see these clear fibrillatory waves. There's no consistent undulation that I can mistake for a P wave, and it is irregularly irregular. The R to R interval in each lead varies, so this is a fib. And to recap, what's the treatment for AFib? Well, that is cardizem. Atrial flutter. Now, you might look at this and think, oh, I'm not sure if this is a flutter or not, because you know what? Looking at lead 2, if we don't do a 12 lead, it kind of looks like SVT, right? I see no clear P wave before every QRS. It's fast. It's right about 150. Well, if you give adenosine on this patient and you kind of disconnect the atria from the ventricles, what's going to happen is you're going to see a bunch of flutter complexes. So just undulating sawtooth P waves. How do I know this? Because I see one break in the rhythm in V1, and I can see 3 P waves here. Now, this is 2-to-1 atrial flutter, but every now and then, if you're lucky, when you're looking at this rhythm, you'll see a break, and I can see these 3 P waves here. So the atrial rate is 300, the ventricular rate is 150. Anytime you see a ventricular rate pinned at 150, not changing, you should really, really think 2-to-1 atrial flutter. And if you look at the inferior leads, like lead 3, you can see this sawtooth pattern. That's why it gets the name. So just picture that the QRS is not there. You'll see this undulation that looks like a sawtooth pattern. AV nodal reentrant, what we commonly refer to as SVT, but we want to now call it AV nodal reentry, AVNRT, AV nodal reentrant tachycardia. You can see that I have a rate of about 3. So from here to here is 300. This is 150. Might be a little faster than that, but there's no clear P waves, and the QRS is narrow, and it is regular. Now, how does AV nodal reentry work? Well, what you see is during a normal sinus rhythm, the impulse is conducted from the SA node, and there are 2 pathways, all right, that it can go down through this conduction system, all right. Generally, it only goes one way, and then it goes, through the AV node one way through to the His bundle, and it is generally only able to go this one direction, this one pathway, because the other pathway is refractory, all right? It doesn't normally travel through both ways. But if you have a properly timed premature atrial beat, so the SA node conducts prematurely down this pathway, imagine that it enters this normal pathway. It enters the normal pathway, but it's still refractory because it just had an impulse coming down it. And it takes time for those pathways to repolarize. Due to the sodium-potassium pump, it has to repolarize. So what it does is it is blocked during this normal conduction pathway, and it travels down. It is now able to travel down this other pathway, and then it finds, once it travels down this other pathway, it finds the other leg or side no longer refractory. All right, and then it creates this reentrant loop where it travels down the SA node and then back up through the other pathway and then back down to the His bundle and to the ventricles. This is AV nodal reentry. That's why we call it that way. There are rare occasions where you can see P waves immediately after the QRS or before the T wave. Now, with normal SVT, they're generally hidden in the QRS complex. That's why you don't see them. They're actually there, but you don't see those. With the common form, you don't generally see the P waves, but there are certain types of AV nodal reentrant tachycardia, depending on how it's traveling, where it's coming from, down those two different pathways. You may see them, all right, but they're not going to be before the QRS. They'll be immediately after. You'll see those little blips like you see in V1. But the most common form of AVNRT, which it travels the slow-fast pathway, you don't usually see the QRS, or you don't normally see the P wave. Or if you do see a P wave, what you might see is a pseudo R wave. So we've got our initial Q, then R going above. You'll see a sharp deflection in that R wave there, and that's actually a P wave embedded in the QRS complex. So what is the treatment? What is the treatment for AV nodal reentrant tachycardia? Well, it's a Valsalva maneuver initially, all right, followed by adenosine. If that doesn't work, followed by cardizem. Or if the patient becomes unstable, it's synchronized cardioversion. How do we do the modified Valsalva maneuver? We've covered this before. I think it's especially useful. Should be our go-to on any patients that are compliant and willing to do so. So with the modified Valsalva maneuver, what we do is we take a 10 cc syringe, leave the plunger in. I've heard people say take the plunger out. No, don't do that. Leave the plunger in. All right, they're sitting semi-recumbent, right? So about 45 degrees, 30, 45 degrees. We have them try to blow that plunger out for as long as they can, 15 seconds or as long as they can. Then once they're done with that, you place them supine. You lay them flat and then you raise the legs for 45 seconds, or about 45 degrees for 45 seconds. And then you sit them up, and then they should convert. This is almost as effective, if not more effective, than giving adenosine. So if you don't have to give medications, don't do it. Now, what about ventricular tachycardia? How do I know this is VTach? Well, I'm not 100% sure, but it's really wide, right? It's wider than I would expect, SVT with aberrancy to be. The QRS duration is almost 0.15 seconds, or 150 milliseconds if I convert seconds to milliseconds. How do I know this is not a right bundle branch block and that they then go into SVT and it's just wide, fast, and regular because they're in AVNRT and they have a right bundle branch block? I don't, but it's wide, fast, and regular. Now, if this was an older patient with a pre-existing heart condition, am I going to try adenosine? No. Am I going to try amiodarone? Maybe. If they're slightly unstable, if the blood pressure's soft, maybe I'll try lidocaine first. But if it's a young, healthy patient and the blood pressure's pretty stable, maybe I'll try adenosine first. I think adenosine would probably be a appropriate choice. Now, the QRS is a little more wide than I would like, for me to think that this is going to be SVT with aberrancy. But if it's an older patient, and they're pretty stable and they have a cardiac history, my go-to is going to be amiodarone. And you know what? If they have underlying bundle branch block, so be it. It could still convert that. If the blood pressure's soft and they're an older patient, then I'm probably going to go with lidocaine. If they're a younger patient, healthy, no pre-existing problems, then I'm probably going to try adenosine first. That would be my approach for this patient. But the rule of thumb is wide, fast, and regular equals ventricular tachycardia until proven otherwise. Where do we get into problems with this? Why do we drive this home? We drive this home because some people want to try to differentiate between ventricular tachycardia and SVT with aberrancy. And what are two medications we give for SVT with aberrancy? Well, they are adenosine. What's the other one? Cardizem, right? Cardizem is a calcium channel blocker, and it works for SVT. So if they have SVT with aberrant conduction, cardizem will also work. A lot of people make this mistake, and they're wrong, and it's actually VTAC. And what do you get when you mix cardizem with ventricular tachycardia? Well, you can get ventricular fibrillation. So that's why the safest thing is to just treat it as if it's ventricular tachycardia. Pre-excited tachycardia, so WPW is what we think of when we think of pre-excitation. It can also be LGL syndrome. But what happens with normal conduction is it goes through from the SA node to the intranodal pathways here through the AV node, and then it goes down the right and left bundle branches. I was about to say block, but not necessarily a block. You get a P. The P is from the SA node going through the atria. Then you got some slowing as it goes through the AV node. And then it goes through the bundle of His. You get your QRS, and then the repolarization is the T wave. With WPW, it's pre-excitation. What does pre-excitation mean, and why do we get a delta wave? Well, it is a fusion, all right? You get the delta wave because of the fusion complex that you get when it travels both through the normal conduction pathway and through this accessory pathway that isn't generally supposed to be there. It gets there earlier when it goes through the accessory pathway, so you see this initial upstroke, this delta wave, and then you get this fusion. And it is common when you have pre-excitation, when you have WPW, to have repolarization abnormalities. When else do we get repolarization abnormalities? With like left bundle branch blocks, left ventricular hypertrophy, WPW. So when you have abnormal depolarization, you should expect abnormal repolarization. So here's what WPW looks like on a normal EKG. Why do we have a short PR here? Well, because of the delta wave, all right? Because there's early conduction here through the accessory pathway. All right, so you got a short PR interval, and then you have a delta wave. How do we know if the patient has WPW when they're in a tachycardia? Well, you generally don't, because what happens is you get this reentrant loop here, and it just reenters. And then it can appear narrow depending on if it is going down the normal conduction system and back up through the accessory pathway, or if it's going through the accessory pathway and back up. If it goes through the accessory pathway, you will get a wide QRS. If it goes through the normal conduction system, you will get a narrow QRS complex if it is reentrant. All right, you only get the classic delta wave usually when they're not tachycardic and it is traveling down both pathways. So what would you call this rhythm? Well, I would probably call this, and I'll pause for a second. What do you call this? Do you see a P wave before every QRS? Nope, I don't. So the P wave's probably buried somewhere in the QRS. It's narrow, fast, regular. We're going to call this AVNRT. What is this? Is it wide? It looks wide. It's hard to measure, right? But it's wide. Is it fast? Yeah, it's fast. It's faster than 150 beats a minute because this is One thick line, one big box to one big box, or one thick line to one thick line is 300. And then two big boxes is 150, so it's faster than that. And it's regular, right? It's not irregular. So what are we going to call this? SVT. Now, what is this? This is wide, fast. How fast is it? Well, let's look. Let's try to find one that's on a R way, or a R that is on a thick line. Here's one. This is almost just one big box apart. So this is approaching 300. Approaching 300. Now, usually the AV node will not permit complexes to pass through it that fast, because the AV node slows things down so that the ventricles can fill. So if I see a rate that is approaching 300 that is irregular, and you see how bizarre this is. I'm not calling this torsades. Doesn't look like torsades or polymorphic VTAC. It's wide, fast, irregular, and bizarre. I'm calling this AFib with WPW. Now, how do we treat this? Well, we place pads and prepare to cardiovert. This is also AFib with WPW. It is wide, very fast, very bizarre. Could this be polymorphic VT? Possibly. So when you have AFib with, why don't we give adenosine or amiodarone? Well, because all of those things block the AV node. And when you have AFib, when a patient that has WPW, that has this accessory pathway, and they have AFib, you block the AV node. Now imagine that it is going through the normal conduction system. With AFib, you can have like 500 to 600 little focal impulses throughout the atria that are firing away. All right. Normally, some get through to the accessory pathway here, but a lot of them are slowed down or blocked by the AV node. When we give adenosine and we block the AV node, those 600 up to 600 impulses a minute have no choice but to go through the accessory pathway, because you gave this medication and blocked it. Now they go through the accessory pathway, and then what happens? VFib. You get VFib. And we talked about a little how to differentiate between torsades versus polymorphic ventricular tachycardia. How do we know if this is VTAC or polymorphic VTAC? Just by looking at the rhythm strip. You don't. You're right. The answer is you don't. You don't know unless you get an underlying 12 lead. What do we have here? Well, the QTC is 460 milliseconds, 0.46 seconds. Is that long? Yeah, that's pretty long. A general rule of thumb is that if you draw a line at the end of the T wave here, all right, so let's say I draw a line here. Let me see if I can get my marker pulled up, and it looks like it's just not showing. But if I draw a vertical line and the line is past half of the R to R interval, so let's say I draw a line directly in between the R to R intervals, and the end of the T wave is longer than that, then I have a prolonged QT interval. All right, that is a down and dirty fast rule of thumb. All right, and then if this patient then goes into this rhythm, what's the treatment going to be? So it looks like they have a long QT interval. We've got some PVCs. I'm getting a little concerned. Oh, they have a properly timed PVC. And then they went into, is this polymorphic VTAC? No, this will be torsades, because this patient had a underlying prolonged QT interval. So how do we manage torsades? Well, we defibrillate. We consider, generally it's 2 grams over 5 or 10 minutes. If you don't know if the QT is prolonged or not, well, we need to treat this somehow, right? Then it's probably okay to administer amiodarone, because what else are you going to do? Accelerated idioventricular. What's the difference between accelerated idioventricular and ventricular tachycardia? Well, generally it's the rate. If it's fast or regular, or if it's fast, regular, but the rate's less than 130, then we generally call that accelerated idioventricular. How do I know this is a ventricular rhythm? Well, I've got some capture beats here, right? So this is accelerated idioventricular, and then we've got some capture beats there. You'll also see this in VTAC. If the rate's 150, it's wide, fast, and regular, but you see some beats from the SA node, because when you go into VTAC, it's not like the atria quit firing altogether. You still can have impulses from the SA node coming down. So here I see some of those capture. They get through to the ventricles, but then you still got that impulse from the ventricles that keeps firing. And sometimes the impulses will merge together, but this is accelerated idioventricular. So is this. And this one is kind of neat because it looks like we've got some retrograde impulses coming through to the atria. So you have the ventricles are firing, and then if the impulse goes through the ventricles up to the AV node, sometimes it can conduct through to the atrium if the pathways, the nodal pathways to the atria are not refractory. If they can accept that impulse, they will do so. Accelerated idioventricular treatment, nothing. Generally nothing. It's observed. You just monitor it, because if the ventricles happen to be the only thing that are contracting, and you administer an antidysrhythmic like lidocaine, amiodarone, you can kill that patient, because you're taking away their only remaining ability to perfuse, to conduct electricity, and perfuse the rest of the body and the brain. Because what happens if there's a complete heart block and the patient goes into a ventricular rhythm? Complete heart block, the atria and the ventricles are no longer communicating, and you suppress the ventricles. Then you're left with asystole. That's what you get. It's a common reperfusion arrhythmia. So imagine if you get a pulse back and you see this, what looks like a wide complex tachycardia, but it's not fast, it's about 120-ish, then don't treat that. Do not treat that. So in summary, anytime you have a STEMI, just place the pads. Sedation and cardioversion in general is safer than medication. So if you're unsure, you've got a patient that's borderline, their blood pressure's marginal, but the patient is showing some signs of end organ malperfusion. They're not perfusing well. Maybe they're a little altered, and you're thinking, I don't know if I want to give medications or cardiovert this patient. The general rule of thumb is if you're unsure, you should probably just cardiovert them. You saw your sedation options, sedate and cardiovert. For sinus tach and AFib RVR, consider that those are compensatory, especially with AFib RVR, even sinus tach, but we generally don't. We know not to treat sinus tach, right? With AFib RVR, you have to choose. Do I give cardizem or is this compensatory? Consider first that this is compensatory before you consider that it's primarily a arrhythmia problem. It's primarily a problem with the rhythm as opposed to the rhythm being compensatory for something else. Can it be abrupt, sudden onset? The patient just went in AFib RVR. They have no hypovolemia, no fever, no other cause. Absolutely, and you can and should treat that. But remember remember that cardizem can cause and will cause hypotension, especially if the patient has poor vessel tone and they're already hypotensive. I cannot stress this enough. Beware of very fast, wide, and irregular tachycardia. If it's very fast, irregular, and bizarre, just assume that it's AFib RVR. AFib with WPW, AFib with WPW. All right, and do not treat that. And I hope that was helpful. A few changes to our protocols that I think they're interesting, that are useful. If y'all ever have any questions, let me know. Thanks.